Hello everybody, this is going to be the part 3 of the MDC 2 lecture exam review. So part 3, we're going to go over a lot of our gastric disorders such as peptic ulcer disease and upper GI bleeding. So without further ado, we're going to go on and get started. Alrighty. Time to look at ulcers. So there are a couple different types of ulcers that are affected by peptic ulcer disease. So you must know the difference between them. So our gastric ulcers are mucosal lesions of the stomach that developed at the top of the stomach near acid secreting mucosas. They can result from diffusion of acid or dysfunction of the pyloric sphincter. Duodenal ulcers are going to be in the lower part of the duodenum. They can be deep lesions that penetrate through the submucosa. There can be necrotic on the granulation tissues and cause fibrosis. They're going to have high acid secretion and excess acid in the duodenum. Protein-rich meals, calcium, and vagus nerve stimulation may occur. Stress ulcers are least common, but they can occur. So they can have acute gastric mucosal lesions after acute medical crises or trauma or a lot of stress, like sepsis or head injuries. And why is somebody being loud as heck? Patients who have extensive burns, sepsis, or increased ICP may also be susceptible to a stress ulcer, GOES or NPO, or have gastritis, may have stress ulcers because there's excess stress on the stomach area. NSAID ulcers may occur, and they're usually from overuse of NSAID medications like ibuprofen. So PUDs often from are H. pylori infection. So H. pylori is a bacteria that can cause ulcers to form in the stomach in different places. So some of our risk factors for ulcer development are smoking, alcohol consumption, untreated stress, spicy food, and NSAID use. Some complications that may occur from ulcers are hemorrhage. They may have bright red vomit or coffee brown bloody vomit. Hematemesis usually indicates upper GI bleeding, and tarry stool may occur too if there's like a lower GI bleed. They may have a low H&H, low blood pressure, black tarry stools, high heart rate. Perforation can occur, obstruction may occur, intractable disease may occur, and then H. pylori infection may remain untreated. Also, medications may actually cause infection to occur, like C. diff. So we also want to make sure we get a good health history. We don't know about if they use alcohol or if they smoke, what kind of foods they eat, do they have caffeinated beverages, are they stressed out, do they have other GI issues, what kinds of meds do they take, do they have cancer treatments, what surgeries they've had. Some of our physical assessment things we need to do is ask for any tenderness. We need to look for if the abdomen's rigid, if there's ascites or inflammation. They may have rebound tenderness and pain. Their bowels may be hyperactive. Indigestion may occur. So this is key to know. So a lot of our gastric ulcer pain will be aggravated by food. So a patient eats a sandwich and they have a gastric ulcer, well, they're going to have pain. Duodenal ulcer pain is going to occur about 90 minutes to 3 hours after eating because duodenal ulcers sit lower in the stomach. Pyloric sphincter dysfunction may occur. There's nausea and vomiting. Appetite may be obstructed. We want to monitor for any bleeding and for dehydration, of course. So we can use an EGD to figure out what's going on in the patient's stomach. So it's going to allow for examination of the esophagus, stomach, and duodenum. It's going to show if there's any ulcers forming. It's also going to see if it's H. pylori infection or if there's any other things going on. It'll rule out and confirm if there's cancer. It can assist us in homeostasis. We can get what you call biopsies. We can isolate bleeding arteries. We can do a lot of stuff. So it's pretty cool. Pre-EGD, remember we got to make sure we have IV catheters. Just for any of this, especially if there's bleeding, we want to have those large IV bore catheters in case we do need to give blood transfusions or IV fluid. Remember NPO about 4 to 6 hours beforehand. We don't want aspiration. We want to be able to get the clearest view of the stomach we can. Remember, the nurse is going to witness that consent after the doctor talks to the patient about the procedure. Some post-op teaching we need to monitor vitals, heart rhythm, all your vitals until baseline. We want to assess our gag reflex. If there's no gag reflex, no food or drink, because we don't want any aspiration to occur. We can use different medications such as H2 receptor blockers, PPIs. One thing that I forgot to mention on here was that for our ulcers, we can use triple therapy, 2 different antibiotics, and a PPI because they're going to help kill the infection, but also treat the ulcer. So upper GI bleed, some key features that may show us that we have a GI bleed going on is we'll have hematemesis, we'll have that dark and tarry stool, low blood pressure, high heart rate, weakened peripheral pulses, acute confusion with our older adults, vertigo, dizziness, or lightheadedness, syncope, low H&H. Remember, for patients who are bleeding, we absolutely do not want them getting out of bed. We should be monitoring their vitals. We should be giving them normal saline. We should be doing neural checks. We need to essentially find out where are they bleeding and treat the bleed. Some lab changes, low H&H may indicate hemorrhage. We may also do an H. pylori test, which can be blood, breath, or stool. However, we're often going to do that breath and stool test. We're going to do fecal occult blood tests. We can do serologic testing, and we can do the urea breath test because urease is a byproduct of H. pylori. The patient swallows a capsule and pudding that has urea, and if there's excessive carbon acids is found, there's that H. pylori bacteria in it, and we'll need to treat that. And that's what peptic ulcer disease is. Some things that we can do, I'll definitely get a very good health history with these patients, determine what's going on. And with that, let's pull up a couple practice questions, because I feel like I rushed through that. Alrighty, let's go to GI. Alrighty, let's do some GERD. So number 1, male client has heartburn at night that awakens him. Which assessment should the nurse ask? Any weight gain? What do we do to alleviate? Consume milk and dairy, and have you been around anyone with stomach viruses? So for me, I would say, since he has heartburn at night that awakes him, I would say, is there any weight that you gain? The nurse, preparing a client with GERD for surgery. When information warrants noting HCP. The client's esophageal test is positive. Abdominal x-ray has hiatal hernia. White blood cell count is 1400. H&H is 13.8. So I would say 3 because that white blood cell count indicates that there's an infection going on. So let's go. Okay, we don't need IBD. Let's do some peptic ulcer ones. So which assessment data supports the nurse's diagnosis in gastric ulcer? 1, presence of blood in the client's stool for past month, reports in burning sensation, moving like a wave, sharp pain in the upper abdomen after eating heavy meal, complaints of epigastric pain 30 to 60 minutes after ingesting food. So gastric ulcers are in the upper of the stomach. Complaints of epigastric pain 30 to 60 minutes after ingesting food, that's going to be your duodenal ulcers. Sharp pain in the upper abdomen is what I would say, because that's going to be possibly there's an ulcer there. I'm just picking and choosing some random problems, because obviously I'm not going to be able to do all of them with you. Let's do the nurse is assigned to care of patient with peptic ulcer disease, which assessment data requires further intervention. Remember, this is negative question. Remember, if it's further innovation, we want to know what do they need to further teach on, or which answer is not right. So, bowel sounds oscillated 15 times in 1 minute, belching after eating a heavy and fatty meal last night, decrease in systolic blood pressure from lying to sitting, decreased frequency of distress located in epigastric region. So, bowel sounds oscillated 15 times in 1 minute. That shows that there's possibly hyperactive bowel sounds. Belching after a healthy fatty meal late at night. That's probably going to be that further intervention if there's a peptic ulcer going on. However, systolic blood pressure decrease, that's like orthostatic. Distress. Decreased frequency of distress is a good thing. So it's going to be 2. I'm going to go with the belching. Don't need colorectal. Not that yet. No gallbladder disorders. Mouth. Hepatitis. Gastroenteritis. Abdominal surgeries. Eating disorders. Constipation, diarrhea. Okay, let's see if we got these right. So 1 is 2. So most GERDs have been self-medicating with OTCs. It's important to know what they've been using to treat the problem. 8, remember that the white blood cell counts elevated indicates infection. 25 is 4 actually, so ulcer pain is going to occur 30-60 minutes after eating, but not at night. Duodenal ulcers will have food and pain occurring 1 to 3 hours after meals. And then 32. And then this shows that there's also orthostatic blood pressures could show bleeding. Those are just a little example of the some questions. Definitely reach out to your resources, reach out to your professors for resources, because the more the better. The more questions that you get exposed to, the better your results will be on your tests. And with that note, I wish everybody good luck tomorrow, and study hard, get some sleep, do some self-care. Remember, you got this. Breathe in, breathe out, and have fun with it. Make it your own. Take all your anger on it, because I know this semester's been hard for a lot of us. Okay? Good luck, everybody. Bye-bye.